Hi, everybody. This is Jorge Gonzalez. I'm the director of TPMed. We are a business association that promotes digital health, and we are now very much focused on digital transformation. That's why we are doing this series of webinars every Thursday afternoon European time. And today we have what we have been told is poster child of digital transformation, in this case from Canada. And we want to thank Peter Bak from Humber River Hospital. I also want to thank Amy because she was the person that put me in contact with Peter and Humber River. Amy was a colleague in the Harvard Medical School executive course that we took together. Thank you very much, Amy. And Peter, we like to start very on time. So the floor is yours. Thank you very much again.
Good. Thank you. Welcome to everybody. You're all behind the camera here, so I don't see you, but hopefully you're all comfortable. So I'd like to present to you today the digital journey that we've been on here at Humber River. And there's lots to talk about, but I'll get through the key points and we can ask questions after I'm done. Let's just start very quickly with who Humber is. We're a community academic hospital in Toronto, in Canada, with 688 beds. And you can see all the stats on the screen. I don't need to read them out. We're a very large facility. We have private rooms, which is unique for Canada, and also influences a lot of what we've implemented here. We have a number of areas of excellence. As you see on the screen, surgery is a big topic for us, as is maternal child. We do a lot of deliveries. But we are a community academic, so most of our medicine here is sort of community oriented. We don't do things like vascular or cardiac surgery or neurosurgery or any of those more complex things. They get done at the academic centers. Let me tell you a little bit about the digital transformation, and I'll get through some of the key points, and then we'll move to another key topic, which is around our command center. When we moved into this building, which was in 2015, the idea was that we wanted to do a business transformation so that we could deliver more care, more acute care for less money. Very sort of cliche statement, more for less, better, faster, cheaper. But in reality, that is exactly what we were trying to do. And we segmented this problem, or thought about this problem, in 4 ways. One was digital information, mobile connected, patient empowerment, and systems automation. Let me tell you what these really refer to. Digital information, for a lot of you in healthcare, you may be familiar with the HIMSS EMR adoption model scale from 0 to 7. And we all think, great, let's all go to MRAM 6 or 7 in our medical record system, and that's electronic. Actually, that is only a small portion of electronic. What it means to go digital from an information point of view is that all information is digital on our network and is actionable. And it's the actionable piece that is that really drives the value out of going digital. In our case, we have implemented MRAM 7, and we say MRAM 7++ because we've done so many other things that MRAM does not measure. But the other key point here is that all of our systems are on our network generating digital data. So this is the building automation functions, our transport systems, our housekeeping, everything to do in the operation of this building and this acute hospital is on our network. You can read all of the things that we've done there, and this is typical of anybody that is trying to move to an MRAM 7 level. We have implemented all of these things here at our facility. The key value of going digital is that you create actionable data, and it is the action that is really what you're looking for. How do you drive efficient workflow? How do you drive safety and quality? You do it by having data available at your fingertips and the right information at the right time. And you support that in a variety of different ways. And you see on the screen here techniques such as virtual queuing, room sign monitors, where we're displaying meaningful information outside every room. We use notification methods, a variety of different techniques. But at the end of the day, what is the theme? We're leveraging our data to drive behavior and performance. The second main theme of going digital is about being mobile and connected. We all understand that in a hospital setting, staff move, patients remain static. So we need to empower our staff to be have the ability to connect with information, but also to connect with each other. And here we create two themes. One is the people-to-people connection, and then a systems-to-people connection. Let me just articulate the distinction here. People-to-people is the traditional way where we talk to each other, and for many hospitals that still means picking up a phone or using a pager. That technology is dated, it's inefficient, and should go. It should be replaced with what we do in our daily consumer life, which is text messaging, in-app communication, and leveraging unified communications infrastructure. So we have done that in this hospital, and we still have a way to go. But unlike the consumer world where we use instant messaging or WhatsApp to communicate, in a healthcare setting, you need a much more constrained and workflow constructed way of communicating with each other. The second key piece is really being able to have all of that actionable data drive behavior of the humans. And so thereby you need a communications platform that will take that actionable data and send messages to the right people at the right time. This is often thought of as alerts and alarms coming from your medical devices, but it actually extends way beyond that, which is that we certainly do code blue, code white, nurse call, we do critical lab results, but now we are doing sepsis alerts, falls risk alerts, bed alarm alerts. We're also doing a variety of notifications for performance that we drive to the individual to keep them informed and on the right action. So these are two big themes, and there are many elements within our hospital where we have delivered enhancement to the way people work through being mobile and connected. I'll skip over that. The next key piece is really about patient empowerment. And this is an area that I think healthcare does very poorly still. We break this problem down in empowering patients before they arrive to the hospital. They can communicate with us online in a very similar way that we engage with the retail world, the travel world. So many other industries are now entirely online, yet healthcare is still very lagging in this area. The ability to book online, to check in online, to register online, to pre-screen and deliver content to surgeons and or others before you arrive online. These are all the things that we should be doing. In addition, once you're here, you want to have to empower the patient to be able to control their environment. And we provide a bedside terminal that lets them control the lights, the blinds, to order food online, to engage with their family members through video calls, all those types of functions we provide. And then, of course, when you leave, we all think, oh, here's your medical record. That's fine, but giving somebody a medical record is not necessarily all that useful. But providing them with care plans and remote monitoring and tools like this that's far more useful, and that's what we're engaged in. So this is all under the theme of patient empowerment, and we've implemented many of these things. Another key theme, which is really ultimately what drives the true value of digital transformation, is systems automation. And many think of this as robots, and here you see a video of our automated guided vehicles. Definitely the implementation of robots is useful, and there are business cases for this. We have an automated lab, we have an automated pharmacy, we have automated guided vehicles, and so on. But at the end of the day, the real value of systems automation is about workflow automation. How you put all of these technologies together to drive an outcome, and a sustainable, repeatable outcome. And here I want to talk about two in particular, which I think are holy grails that all hospitals would like to achieve. The first is our laboratory round trip, as we call it. By virtue of the various technologies, we now have a guaranteed 40-minute turnaround time from placing the order for lab to the results being in the hand of the referring physician or the ordering physician. In addition to this, we have 0 labeling errors in this hospital. And we do well over 4 million samples a year. And as you see on the screen, this is combining CPOE. We then have a mobile phlebotomist cart, which has a dashboard of all the orders. We do bedside verification and labeling. We use our pneumatic tube system to deliver the samples from the floors to the lab, fully automated track, integrated with our medical record, critical lab results, alert straight to the handheld device. Another example is our pharmacy round trip. In this hospital, we have 0.0001% medication error. This is as a result of the combination, again, of CPOE communicating to the pharmacist for verification, fully automated dispensing and delivery, bedside verification. This is the holy grail that all hospitals are hoping to achieve, and we have it here, care of combining these technologies together for that outcome. Here you see what our inpatient unit looks like. This is a med-surg floor. We have 32 beds on a unit. The picture on the left is looking down our hallway to 2 units, east and west. This is middle of the day. We generally run at around 100% occupancy, and that is what it looks like. It is calm, it is quiet, it's not cluttered. Where are the staff? They are bedside. We have found that by use of the technology and the right workflows implemented, we are able to increase the amount of time nurses spend with patients by a factor of 2. We have maintained our same nurse to patient ratio that we had in our older buildings, which were semi-private and ward rooms, to now in this facility where we are single private rooms. So this gives you, and for many clinical people that visit our hospital, this is what really shakes them and they go, wow, look at this. This really represents the consequences of all of this technology in play. The facility has created a whole load of improvements and enhancements, and these are some of the statements that we can make. We have seen lots of benefits accrue from the implementation of our digital technologies here. And as I've already said, some of the outstanding ones are that we have 0 medication error, 0 labeling error. We also have significantly reduced infection rates and reduced length of stay. So many benefits to talk about that we have achieved. let me talk about the next phase of our transformation. All of that digital technology was deployed over the course of 2010 to 2015. And then we opened our doors and we started to refine. But what we then found was that the bed capacity that we had was going to be superseded by the demand very quickly by 2020. So we started to think about how we would solve this problem with looking at how we could increase bed capacity without having to actually open up more physical beds. And this took us into the journey of our command center. Let me play this video, which really tells the story. Hang on a sec. We don't have sound.
There is an option, Peter, in Zoom. I think where the audio is that you have to click saying that you want to hear the. It's usually it's in the bottom of the screen.
Where do I find that?
Let me see.
Sorry, everybody.
How important is the audio? Can you walk us with your own? Can you walk us by basically explaining what the video says? So it's very critical that we hear the video, Peter.
Hang on, I'll just turn off my video. Okay. All right, that's a bit, that's a shame, but that's fine. Then we'll move on from there. We'll skip this video. Okay, if you can maybe find out how to do this, then
yeah,
videos.
Yeah.
So we implemented a command center, and the whole idea of the command center is to drive efficiency so that we can create capacity by essentially optimizing the processes, leveraging data. So this is what our command center looks like today. This has been in operation since late 2017. And let me describe a little bit about what a command center is and what it does. So a command center is a combination of four things: a physical space, which you saw, but then a whole series of analytics that are packaged into dashboards, or in our case, we use the word tiles. And these analytics are very focused on driving process and ensuring that our teams are focused on the right action at the right time. And associated with the analytic is what we call an interaction procedure operating mechanism, or IPOM. What is this? This is essentially an action that we take. So when we see something happening, which is an alert happening in the ED or something, that's when we say, oh, okay, take action. So the staff members in the command center will then organize for people to jump onto a topic and resolve it before it causes too much consequence. The fourth piece here is the communications piece. And within the command center, we today pick up a phone, but ultimately we want to integrate into our communications platform so that all that knowledge of who needs to do what can be communicated onto their mobile devices. So when we implemented our command center, we had 3 generations of command center in mind. The first was to deal with patient flow and patient care logistics. And that is the first piece that we implemented, and we saw lots of benefit. I do want to show you this video, and I just want to know how to get this audio going. Jorge, is there any info on how to do that?
I mean, is the video in YouTube or something, or you have it in where we can access and play it, for example, from our computers? Otherwise,
Command Center.
Now it's
we can hear.
working.
Now it's working.
You made a trick, Peter. Okay.
But equally as their journey throughout the hospital, and how can we reduce that journey so that it's shorter? So there's specialty tiles, there are 22 different tiles behind me, and they will help us with that. So for example, we have a medical imaging tile. And you might say, well, how on earth did you shave so much time off getting an ultrasound done? Well, you know what? When you have it right in front of you and you have the person that's managing that sitting right here with the rest of the team, you're able to do that. Discharge planning. We're looking to see, okay, this person can be discharged, but they need to have 3 things done. How can we help those clinical teams to get them done? Physician delays. We're looking at, oh, why does that physician have 30 patients and this other physician have 10 patients? What can we do? Unit under pressure. We're looking at, oh my, why is that unit, has really high acuity where another unit doesn't? You know what? Let's move our patients to the area with less acuity. Allied health. Why is a patient waiting for a physiotherapist or a social worker? What can we do to try to change those? Any care delays? If a patient has a high creatinine and we know they can't have a CT scan with that high creatinine, what are we doing about that? And what are we doing about it proactively early? So this is the kind of information that we went out to our clinical teams and we said, what can we do to help? They came back and said, this is what you can do. And so we were able together to build these tiles where we work with all the clinical teams to make sure that that experience of the patient, they get in quickly, their stay is short, and they go home with the supports that they need. So
right.
It's key.
So that's Jane Casey. She's the director of our command center as well as of our ED. In the essence of time, I won't dwell on all the details, but here she there expresses what the power of the command center is all about. This is an example of a tile, as we call it, and you'll see on here lots of information about the ED status. This is a very core tile, and one of the things that I'll come to the benefits. Here's another example of another tile. Here we're using machine learning to do prediction 48 hours ahead to determine transport requests and staffing requirements, and at the bottom there are house cleaning requests and staffing requirements. So these are all the kinds of things that our command center does to help us achieve things. I'm going to pass on Jane there. So what did this first version of our command center do? It essentially, there are many metrics that we measure, but essentially it created 35 beds of virtual capacity without hiring additional nurses, without creating new beds. And it's done that by changing metrics all over the place. And one of the very meaningful metrics in our world, by virtue of those 35 beds, we've actually been able to generate about $11.5 million of savings per year through all of these efficiencies and increased capacity. That dollar figure is very dependent on the funding models that are in your countries. That's a number that relates to us, but not necessarily to everybody. Irrespective of the dollar figure, you see tremendous improvement here. One very powerful metric that I will cite is that here in Ontario, the average wait time from ED admission to in a bed is around 18 to 20 hours. In our hospital, our average time is 5 hours. And that is because we are leveraging our command center to improve the efficiency of flow. The next piece that I want to talk about is the shift that we've done for our third generation, which is really to solve a lot of the problems of harm in hospitals. And every country in the world struggles with this issue. In Canada, our measure is 1 in every 18 hospitalization leads to an unnecessary harmful event of various degrees. Our goal is to eliminate those. And by virtue of eliminating those, that inherently implies lower cost, potentially reduced lengths of stay, increased capacity. So this was our generation 2, and I'm going to ask our medical director to talk about this.
We have implemented 4 new tiles, which really do focus on early warning signs. So when the patient is starting to deteriorate, it alerts our frontline staff and the staff in the command center to take early action.
The work that's being done through the command center is the first of its kind, and that's an exciting thing to be a part of. The entire concept around the second generation of the command center is very appealing. Any opportunity to provide a safer environment for patients to receive their care is ideal. We have some really invigorating and innovative alerts that are coming as a part of our second generation tiles that will give the clinicians a feeling of support, to have that backstop there, to have the support from within the command center and at the bedside to help with clinical decision making, but also for our patients to understand that we, unlike any other hospital, have this safety net that's in place to really support greater patient safety and quality of care.
We have a
So the second generation focuses on a variety of topics, but at the heart of this is all about deterioration and monitoring of that. So things like sepsis, falls risk. One big area is perinatal care and doing fetal heart monitoring and being able to intervene if things are going sideways for babies. This was implemented, we've been live for a year. And one of the things that came out of this is that we're using an early warning score that's founded on the UK NHS News 2 score. We implemented that score directly into our Welsh Allen monitors, so nurses see that score instantly, but it all flows to the command center and allows us to really watch what's going on. I'll skip over this video in the essence of time, but this is really a description of how we track the status of patients and can intervene to avoid unnecessary code blues and sepsis and various other things. We also worked on the pandemic, and we implemented a COVID tile, and by virtue of that allowed us to manage our COVID population from our ICU into surge bed and med surge rooms. One of the things to note there is that we started off with a COVID floor, and then we overflowed from that, and we said that really isn't going to work. So we started to put COVID patients in and amongst non-COVID patients, but we managed all of that very carefully by means of the command center. And it gave us the flexibility to deal with capacity as required. So very finally, the third generation of our command center and the next phase of our digital journey is really to look at how we can now actually reach into our community and reduce the unnecessary acute utilization. If you look at the theme here, we tried to become better, faster, cheaper, which we did in our digital transformation. Then we said, let's create capacity. We did that. The second piece was say, let's eliminate error and drive quality and safety. We're doing that. And then the third step is really to say, well, let's avoid the unnecessary visit to the hospital by being able to manage the patient in a home and community setting. And this is a theme that we are seeing all around the world, where we're shifting from the old sort of 50s and 60s disease state model to the chronic disease state model. And the way that we're looking at this is leveraging technology into the home setting for remote monitoring, tied in with our command center, but also tying in the full circle of care, including primary care, allied, community care, and so on. Let me just play this video to give you a
Next step,
feel for
this
this.
whole business of actually treating patients in the home and minimizing the admission into the hospital. But this one is a more interesting challenge from a technology point of view, because now how do you get all that data from the home setting into the command center and the communications flowing out to those that need to go and look after that patient in a cost-effective, very simple way? That's a challenge. We're looking at robotic technologies that are companions in the home that allows us to communicate with the patient, but that robot can also help the patient guide through the actions that they need to take. Remind them that they need to take their medicine, remind them to get out of bed. We can talk to them, they talk back to you. This is exactly what we want in the home setting. Add to that the idea that that robot could actually take your vital signs for you. And now we've really got a powerful piece of technology that lets us manage those patients in the home. This is where we're headed. This is not super way down in the future, but this is actually next year.
So that video, one, I have a haircut there and I don't have COVID hair. And two, that was done a year and a half ago. And so now is today. We have implemented a technology platform, which we call a medical grade social network, to support care plans for patients as they discharge from here. And we can track and monitor their activities. We can guide them. We can give them support. And this is a new initiative that we're just starting on, so we will be expanding this. With the pandemic, this drove us to focus in on COVID and surgical transition, but ultimately this is for COPD, CHF, diabetes, and chronic diseases of that nature, which will ensure that we can reduce readmissions and ensure that those patients are managed and comforted in their home setting. On that note, I'm going to conclude by saying our whole digital transformation has really all been about creating capacity, reducing costs, driving enhanced safety and quality in the pandemic era, managing COVID. But the next whole phase, which we're engaged in now, is really looking at shifting to a world where we're managing chronic disease more efficiently than we are today. Open to questions.
Wow, Peter, thank you very much. This has been incredible what you have shown us. I want to say that whoever has questions, please use the Q&A, question and answer button that is below on the bottom part of the screen. I will read them and then Peter will answer. Meanwhile, till we get some traction in the Q&A, Peter, I'm curious. Have you worked out the economics of the command center? How, in terms of, like, I can see, I mean, I can tell that this has been an investment, that this has not been cheap. If maybe correct me if I'm wrong. What about the returns? You know, what do you think the return of? Can you tell us something about the return of investment of the command center?
Certainly. So in our case, the return on investment was under 2 years.
Wow.
And that is a reflection on our funding model. I've had this conversation with people in Europe, and I totally understand that funding models are quite different from country to country. Canada is a entirely public funded medicine system. We are not like the US, where it's private medicine. In fact, people joke about Canada, where it's the one of only 2 countries where we are purely public, us and Cuba. But even in that environment where we are publicly funded, we were able to derive net profit to the bottom line to fund the command center. That may not be true in all circumstances, but we absolutely see so many metrics move that translating that into a financial benefit should be very possible, no matter where you are.
We have our first question for the audience, Peter. I'm reading that to you. Robots, especially anthropomorphic, in the home are controversial. To what extent will they facilitate empowerment, self-management, for example, as opposed to just informing? Why do you need a robot when an iPad will do the same? Ask Malcolm.
Very good question. So the answer to that question is technical equity, or at least that's our language here for it. Essentially, our population here is very low income, and at the lowest income community of the city, and not everybody has access to technology, and we have a lot of elderly live at home alone. So when thinking of the elderly population, which really is the cohort, the predominant cohort with the chronic disease states, to assume that they can handle iPads or smart devices, that they have internet service, that they can do Bluetooth pairing and all that kind of stuff, this is not the community that we are serving. So our belief is that when you provide essentially a fully contained, no questions asked device that you literally just plonk in their home, with 5G connection, fully self-powered, and everything built into it, then that solves the digital equity problem. The robot that you see there really is just a sophisticated version of Google Home or Alexa or an iPad. But we package it in that form because we believe that has value as a companion function to those elderly live at home. And that's the reason for the robot. The robot, other than that, is really not necessary. You could, as stated in the question, easily solved by simply iPads and smart devices.
Thanks, Peter. I have a question. I don't know, you seem very technological in all aspects of the hospital, but in terms of digital transformation, with the focus in the word transformation, that is the strategy, also the leadership, the culture, the capacitation. Do you still struggle with any of these topics in your organization, or you are kind of beyond that?
So this is a really key point and topic. So thank you for asking that question. My experience with all of this is that you need very strong leadership to engage in a business transformation of this nature. And I'll talk about pre-pandemic and now post-pandemic. Pre-pandemic, our experience and my personal experience in the system in Canada, but also around the world, I have been to many countries to discuss these topics. One of the observations I have is that there is a lack of strong leadership to drive the business transformation. So often we talk about, we present this material and CEOs of hospitals say, oh, you guys have done that. I wish I could be like that, but there's no way we can do this. And I look at that and I go, what do you mean there's no way you can do it? Of course you can do this. Well, we're not magicians here. We're no different than you. So this is about leadership, and this is about leadership at the hospital level, but also at the physician level and at the government level. And I'm a strong advocate for saying leadership needs to stand up and say, we need to do this in healthcare, and it is unacceptable to not do this anymore. That's the first step. There is obviously change management requirements to get everybody to engage. But my experience with this is that the fear of technology is one that is dissipating over time. The more technology used in our consumer life really dissipates the threat of that technology in the healthcare setting. And so certainly in 2015 or 2010, we had lots of people going like, oh, there's no way that we're going to be able to do this. But today, that is no longer an excuse, and I don't believe that you'll see resistance from that point of view. So really this is, and then the third item is the dollar figure, and people believe that it is an expensive proposition to invest in technology. And I would argue that that is not the case. If done correctly, your dollar investment is actually not as scary as many believe it to be. if you look at our hospital, the total spend on technology in this entire facility was less than 5% of the complete spend on building. In any metric that of any industry, that is a low number. It can be done, and if done correctly.
Okay, thank you very much, Peter. We have a question from Marie Sherman. It is in the chat. Says, any follow-up studies regarding patients' reactions or appreciation? And she has a follow-up question regarding the staff, but let's go first with the patients, Peter.
Sorry, can you just, I missed that.
Yeah, it is not in the question, it's in the chat. It says, are there any follow-up studies regarding how patients react or appreciate your digitalization efforts?
Yes. So we definitely see patients appreciate the indirect impact that the command center has on the quality and the safety for patients here. It is noticeable to patients. They don't see the command center, they don't see all of that technology in play, but they definitely recognize that their visit to this hospital is quite different than they have experienced at others. And we're not talking about comfort level and so on, although that of course is one factor, but that's more because we're new and more shiny. But some of the features that they experience here, they definitely comment on. Other areas that we are seeing is around how they engage with us. This is a more recent area that we're working on, but we are seeing patients report back that they appreciate the way in which they can engage with our facility.
And about the staff, Peter?
Hang on, the staff definitely, why don't I just...
Yeah, yeah. Stop sharing the screen. No need. Thank you. Great.
So the staff have found that the technology actually makes a big difference for them. So I will say that on the nursing side, when we talk to our nurses, they definitely find the environment in this hospital far more satisfying for them to do their work than relative to others in the city. That is because they're empowered to spend more time with patients, and ultimately that's what nurses find, that's their skill, that's what they wish to do. But the other interesting part is around the physicians, and when we implemented, there are many things around the technology that are frustrating for physicians. There are certainly things a little bit harder to do than if you did it on paper, but ultimately and overall, I think they recognize that this environment allows for better medicine, and that is what they appreciate. And I think what reflects that is that when we hire physicians to our facility now, in the past, we would not be seeing the top ranked physicians apply for jobs here. But today we are seeing much higher quality physicians wanting to come and work here. And I think that is testament to the environment we've created.
Excellent. There are a couple of questions from Malcolm regarding the robots, but I think I want to give chances to everybody. So I will first go with Carlos' question regarding, did you have any help from a consultancy for the deployment of all that stuff, or did you deploy the solution by your own?
So two parts to that. We relied on vendors to implement a lot of our technology. We did not build any of this. The command center is GE, our communications platform is ASCOM. These are companies that are in, you're all familiar with. But in terms of understanding what we want and what problems we were trying to solve, that was my team. We did that internally, and I'm a very strong proponent that you need to build that skill set in your organization. If you outsource that to a consulting agency to do it, there is a danger that you're really just going, okay, you guys do that, and you don't engage yourselves as deeply as you should. But certainly the technology deployment leverage companies to do that.
Right. Before getting into the robot thing again, I would like to know how is the process, Peter, your governance, so to say, in order to say how to set priorities in terms of investment regarding digital. Yeah, I mean, I guess it's clear the question. How do you prioritize your investments?
So the prioritization, so let me start with starting at the leadership. We had a CEO that was, a strong, drove the agenda for doing digital. So we, first of all, had a willingness to spend money on it. The second thing then was to really look at where do you see the biggest return on your investment? And for that, you need to have that clear focus of what problem you are ultimately trying to solve. In this hospital's case, we were trying to solve efficiency around staffing, and that is how we came up with, well, where do we apply these technologies? How do we build business cases around each of these? Robots have a very clear business case. It's very simple to compute. When you deploy communications platforms, it's more complex. But our decision-making was driven very much by what were the top priorities or problems we were solving, which technologies address them, and where did we see a return on those investments. That's how we came up with where we would spend our money. So there was a whole process.
But it's always coming from the top, or how do you engage with the staff? How do you get the list of topics? Maybe the prioritization is done by topic. In order to get what are the areas of improvement, the priority ones, how do you do that?
Right. So that comes this way.
Okay.
Starts with, in this case, myself very much saying, okay, you've got a vision. How do you break that vision down into areas that you want to solve? So that was sort of a top-down approach. But at the same time, we engaged with every single department and every single unit and went through a classic process of saying, what are your main areas of pain? What would you like to improve? On a daily basis, what is the thing that drives you crazy that you would want to have go away or fix? So then you come in from the bottom, and it actually is not a miracle or surprising that what is being said at this level actually matches to what you're trying to do from the top. So it meets, and by virtue of that, you actually get very good buy-in.
And how did you collect those? Did you make a survey, or it was meetings? How did you collect that from the bottom up?
Right, that's basically an engagement process with every director, the managers, and we created a framework for which to think through their, when asked, what problem are you trying to solve? And actually, it's a very simple framework, which is think of a day in the life of a patient, a day in the life of your department, and where are all the areas that drive you crazy? And you can break that problem down quite nicely into before people arrive, when people are here, when they leave, management of staff, and so on. And that was a framework we used, went around every single department and said, okay, given this, tell me what you think. And we captured all of that.
Now, regarding the future and your reference for the future, obviously MRAM is no longer a reference for you. I think you have broken it. Okay, you have broken it. So, what is your? Do you have any kind of guidelines or any kind of I don't know, path finder? I don't know. What are your reference regarding the future, the coming years?
So, our focus now is on two very simple ones that we would use, which is how to reduce readmissions, how to avoid unnecessary admissions. Now, there was a very undefined statement there. But here in Canada, in Ontario, we use a thing called quadruple aim. And so that becomes a guideline for how to measure success. Ultimately, what we're really trying to do is see if we can change outcomes of getting patients out of the hospital sooner into their home setting and managed in that home setting cost efficiently. That is what our immediate focus is right now. That is a little harder to shape and define. And so part of what we're doing is actually learning as we go. It's easy for people to say, oh, like, here are some nice outcomes metrics, go for that. Yes, but what we're experiencing is it's not so straightforward. So unfortunately, I can't give you a nice, clean, faster, cheaper, better. That actually is not what we're trying to do anymore. We've done that. This is about patient outcome and trying to reduce the amount of acute utilization that the system requires.
Right. How did you bring staff, especially clinical staff, on board? Say, if they are not very digital literate. I mean, how do you change a little bit, capacitate them, but also change the culture and align top down with bottom up in that respect?
So this may sound a bit harsh, but to begin with, the strong leadership from the top is what facilitated that. In simplistic terms, what that means is get on the train or get out the way. And right, and I know it sounds harsh.
And you are 100 public. It doesn't look like a 100 public system, but I congratulate you for that.
It obviously isn't delivered in that harsh way.
I know.
But fundamentally, that's what we're doing, is saying, guys, the world is changing all around you. How can we sit here and not change? Like, really, it's unacceptable. So get on and help make that change, or get out the way. And the reality is that a lot of people step up and engage. They actually wanted to help do that. So it was not a lot of resistance where people are going, screw you, we're never going to do this. On the contrary, people are going, okay, but help us along. Like, we don't know how to do this. Mm-hmm. That's the bit where the leadership and the right processes and capacities have to come to bear. What we found is that, sure, you have resistance. There's always people that go, I don't want to do this. It's not, I've done it this way for a million years. Right. I'm not doing it this way. You're going to get that. But the world is changing. So, around you, it's very difficult for people to hold to that position. So the tide will sweep people in. You have to just help facilitate it and move it. What we then found was that once people engaged and you got the first results and they saw the benefit that derived from that transformation, it opens everybody's eyes to go, oh, wow, that actually wasn't so bad. In fact, we want more of that. And one of the things I would say is the most key thing of this hospital, or characteristic, is that we have a culture of change now. Mm-hmm. We have people asking for improvement. It's not a top-down push anymore. It is the front line who are continually saying, I don't like it this way, we can do better, let's do it this way. And my team is responsible for reacting to that. And that is something that I find is thrilling, because now you have an organization that wants to forge ahead. Completely different culture from 10 years ago.
So how long it took, more or less, to get into that culture of change that I really envy you for?
I think that it took us probably 8 years to get there, and the building was a catalyst to drive that.
Right.
Today, I would say that our healthcare system should be able to achieve that kind of culture change in significantly less time, because many others have already done this, like ourselves, and there is evidence of the benefit. But the other really important catalyst that is forcing us to do this is the pandemic. So I absolutely believe that in 5 to 10 years from now, we will see massive digital transformation across healthcare systems. It is no longer a choice. It is about getting on and doing it. And the pandemic has just lit a fire under all of us to go do it.
Right, fantastic. Peter, I'm going to come back to the questions from the audience. Malcolm is coming back to the topic of robots and companionship. He's wondering if that humanoid aspect is true. Is that because they compensate, say, for COVID isolation or loneliness, or do you have any kinds of evaluation of their impact, so to say?
I really can't offer good commentary on this yet. This is an area that, you know, we've only just started to explore, and we haven't yet been able to measure it. The evidence that I work from is from China. I've done a lot of work in China, and this is a topic, a very, very big topic for them, given their aging population and their one-child policy and the consequence of it. So they are very focused on how to provide companionship for the elderly alone. This is what sort of gave me impetus to think about similar things for us here. But I can't comment on whether it is the right way or the only way. It is yet to be determined.
Right. There is also a comment from Malcolm about the voice assistants and Alexa. Do you want to comment from your side? What's your opinion on those?
This is exactly what we're thinking. You know, technologies like Alexa and Google Home are maturing so rapidly that we are moving to a world where everything is voice activated. And this is what I'm counting on, is that what we're building an application that manages the care plan, the tasks, and all of that clinical aspect, but married into the platform of something like an Alexa, where you can leverage the power of voice command, automatic translation. This is another topic, is that we have many different languages spoken in our community and not all speak English. So our systems all have to be able to be support all of those different cultures and languages. People like Amazon, Google, Microsoft, they're solving those problems for us. We just want to leverage them.
Fantastic. There is perhaps the last question. It's from Mary again. She asks, what caregiver is responsible for the home care? Any collaboration problems between where patients end up in the gray zone? She's referring to the transfer of care and home monitoring.
Right. So this is definitely a topic of focus here in Ontario right now, which is why we're engaged in this community outreach and the ability to monitor. We have community home services, which is part of our system that manages people in the home setting. But the people that go to the home setting, there's obviously a limit, and maybe you'll see a PSW, that's our term for workers that will go and visit maybe once or twice a week to see how you're doing. This is the challenge. So how can you provide 24/7 support to that patient without having to have armies of people running around or sitting in call centers trying to track you? Mm-hmm. This is what we're trying to solve, leveraging our command center concepts and the technology platform that we're building out. And the transitions of care, as you say, the gray zone where they fall in between, that's exactly what we're trying to track and ensure that all people involved are aware of what's going on so that things don't fall through the cracks.
Fantastic. Peter, fantastic, really very great talk. It's amazing what you guys are doing. I think that I was short when I was telling that you were the poster child of digital transformation. So really congratulations for the good job and for sharing with us your insights, your learnings, and what is possible, actually, what is possible if there is a willing and a strong leadership, which I completely agree. If there is no strong leadership, there is nothing. I don't see any more questions, and we are on 1 minute behind clock time. Do you want to finish with a closing remark, Peter, or anything that you want to share? If they had to retain anything from your talk, what will it be, Peter?
I'll repeat myself, which is that you know, I've lived this for 10 years or more, and prior to my work at Humber, I've been very engaged in the Pan-Canadian Electronic Health Record Initiative. I've traveled to many countries and assisted as a consultant to help them with their you know, EHR rollouts. The message that I have, and I'm a very firm believer of this, is that technology absolutely can change the way that the quality of care that we can deliver. And the entire healthcare system around the world has to engage in making this transformation. And I believe it's unacceptable that we prolong and procrastinate on this topic. It is not necessarily an easy one, but systems around the world must engage in this and focus attention. That is really the key message I would like to preach out to the world, and look around to those that have made tremendous progress, because they are shining lights of how to do this. There's no longer an excuse not to do it, and the pandemic is telling us that square in our face. So please, and we at Humber are very much willing to share as much knowledge and experience as possible. We are going to be engaging in websites and education materials, not for profit purposes, but to really spread the word and help those that want to engage and do this.
Fantastic. I think those are great closing remarks. Peter, I want to thank you again for your time and your insights, and thank you everybody in the audience for attending this webinar. Remember, we have next week at the same time an opportunity to hear about the Swedish case in digital. Well, it will be more in terms of transformation. Okay, Goran, and I thank Marie Sherman, who is attending today, for putting us in contact. The same, and I appreciate and very thank Amy instead for putting us in contact with Humber River, and in particular with Peter. And this is it. This is the end. Hope to see you next week. Bye to everybody.
Bye-bye, everybody.
Thank you. Bye.
Bye.